Welcome everyone to this video on responding to a mass casualty event. When we are talking about casualty event, we are talking of deaths in teams of hundreds and thousands. So yes, how do we respond in such dire circumstances is what we will be learning in today's video. So the agenda is very simple. It's understand the rationale, the elements, the action that is required for mass casualty triage, discuss everything, all sorts of hazard, scalable causality, management approach, and potential hazardous nature, stressful resource stress or resource constrained circumstances. And believe me or not, when things goes wrong, it goes wrong in every direction, and that is the reason why, despite the best of preparedness, you see the key person would be dead, or probably the key persons are missing, the resources are haphazard, you are not in yourself to undergo or recall the training that you have undertaken at all. The drill goes for a toss. This is what we are looking at it. Obviously, yes, we'll talk about the concepts and the principles of mass fatality management. And we have just seen, in fact, the whole world has seen approximately 3 years back what a pandemic that struck. It was a mass casualty that was actually occurring in every nooks and corners of the world. And definitely, yes, at the end of the day, there's nothing like professionalism and ethics in mass care. Now, this is what the pic will tell it to you. This is the tornado that comes around it. When disaster strike, the fundamental understanding is save the maximum lives. That is it. Simple and straight. Maximum benefit for the maximum number of people to be saved. So, what are we talking around here? We should be talking about day-to-day emergencies, the greatest good in individual numbers or individual patients, the large-scale disaster, the greatest good for the greatest number of potential survivors. If we can have a sizable people who have been saved, the job is considered to be well done. Instead of it that we are only saving few people, few critical people, few important key persons, probably the job is not done per se. So, general principles. What are the triage? Treat first, treat last, and separate whom to do and whom not to do. What are we looking at it? As the case might be telling it to you. General principles of mass casualty triage is the most serious people who have a reasonable chances of survival. Treat them at the immediate urgency. And those people who are least severely injured or illness and they have very unlikely to survive. Now treat them last. Who have the least severe illness or injuries or very unlikely to survive. Something which is on an extreme. If I am ill or I am least injured, probably I'm able to survive on my own. Treat me last. But if I have I have life-threatening injuries, and probably in all probabilities I will the demise is and eventualities for me. Probably then also treat me last. But this is what you need to understand. Maximum benefit for the maximum of the people. Treat the people who are seriously injured but who have a chance of survival. Treat last the people who are grievously injured and have least chances of survival. Also treat last for the people who are least injured or illness and have sizable chances of survival and they can manage on their own. So we need to separate who requires minimal treatment, no treatment, and intensive treatment. So get to them, segregate them, prioritize them, and ensure that this thing happens. So let us talk about the mass casualty triage. One is a systematic method. Next is the organization of casualties and occurrence at the same level can be prioritized 1, 2, and 3. Remember, mass casualty triage decision encompasses presence of life, limb, vision, and threatening condition. This is what happens to the victim, but what happens to the environment or to you? Do you have the life-saving interventions, the tools, the medicine? Do you have the transportation for each of the patient or victims? Now, this is that needs to be understood. So yes, we are talking about systematic method. We are talking about organizations of casualties and the occurrence per se. Now, these are things that we talk about it, but also the fact as a what are we looking at it if there are people who are still breathing who have lost any of your limbs, or probably vision is not clear, can you look at them? This is, can you segregate those victims, prioritize them, and then probably match it with what kind of facilities is available with you in terms of medicine, in terms of equipments, in terms of distance to be traveled or covered in for the transportation. Now that needs to be understood. Mass casualty triage system is care flight. We have the pickup facilities from the helicopter, Cicera, home bush, jumpstart, military triage, you name it, and we have it. There are a number of societies and non-governmental organizations, governmental initiative who have their own way of contributing during casualty. But we'll talk about the salt triage for better understanding. We'll also speak about the start, that is simple triage and rapid treatment. So, mass casualty triage. The US is moving towards a national standardizations of mass casualty. Federal Interagency Committee on Emergency Management System is implementing on Model Uniform Core Criteria, that is MUCC, as a national standard for mass casualty triage. We'll talk about SALT triage. SALT meets the MUCC as in Model Uniform Code Criteria, as a case might be. That needs to be understood. All agencies should use Model Uniform Code Criteria compliant triage system, which will be interoperable with SALT. What is SALT stands for? SALT is sort, assess, life-saving interventions and treatment. So you need to sort the victims based on the grievous nature of their illness or injuries, assess their potential of survival, then probably look what kind of intervention do you it is available with you. That's life-saving thing, and proceed accordingly. Treatment. So salt triage is what we should be looking for it. Yes, we are talking about step one, global sorting, as in first, is it people who are seriously injured? Assess them first. People who have probably some kind of purposeful movement, from some kind of intention to live around, probably with right intervention they might survive. Assess them second. And people who can manage on their own, they are injured but they can manage on their own, probably assess them third. And that is what how you rank your victims accordingly. Step number two is individual assessment. This is what we are talking about it. LSI is life-saving interventions in terms of major hemorrhage, open airway. If you're there is a block in your airways, chest decompressions, auto-injector antidotes. You need to find everything, every intervention that you take. You need to come up with certain monitoring results, wherein you will need to find out whether the victim is breathing, yes or no. If no, to be presumed to be dead. If yes, obeys to the command, simple theory, simple purposes, raising your hands, lowering your hand, respiratory distress, any hemorrhages and control. Again, you will be assessing the situation. If there are all good, probably minor injuries, minimal. If not good, likely to survive, try to understand what they are looking into it. If they are likely to survive with the requisite intervention, treat them immediately. But what happens if the treatment is missing? So probably you need to understand the eventualities thereby. So sort triage is what we are talking about, is sorting, global sorting, as in assessing one as a life-threatening disease, wave, purposeful movement, they assess second one, and walk third, people who can manage on their own. So rapidly identifying the most at risk by sorting the people, limiting them. Many are hearing, many are afraid of, many are injured physically. The life-saving interventions I have actually discussed with you, as in what needs to be done. Every time that you have sorted your patient or your victims, give a medical intervention based upon the medical intervention, whether the patient or the victim is responding or not. You need to check everything and probably update the intervention process thereby. And until and unless the victim has come back to a reasonably healthy state of life. Now that is what we need to go around it. This is your life-saving intervention that needs to be purposely footed and should be focused upon it. So major life-saving interventions are control major hemorrhage. Hemorrhage is blood flow, uninterrupted blood flow. If is it happening, you are only losing your chances with every passing moment, with every passing oozing of blood. The victim is losing his or her life slowly but steadily. Open airways, if there are airways that has been blocked, decompressed chest, auto injector antidotes, as the case might be. Yes, we are talking about the LSIs. We need to understand what the patients are doing and how it has been doing around it. Whether the patient are responding to their chances of breathing. Yes, no. If no, there is it the eventualities that we are talking about? If yes, can we go into the normal things as in the commands, as in to follow the instruction, see how heady the belly pressure the patient is feeling, how is the victim reacting to general scenarios as the case might be. Now, responses to interventions, does the victim respond to commands? Probably movement or eyelids, movement of your limbs, probably fingers, peripheral pulses. Can you feel it? Can you feel your pulses? Respiratory distress, as on the cases might be, people might not be able to take their breathe very properly. They require some sort of assistance. Check for the bleeding or the hemorrhage, has it stopped or not. Based upon it, can we categorize people and probably assign the ribbon altogether. We have five colored ribbon that goes around here, which lets you tell us what kind of action that needs to be taken forward. The red denotes immediate action on the victim. The yellow denotes might be delayed, requires attention, but you can skip for the time being. Minimal is green, probably it's almost 80 to 90% healthy and requires a little to no assistance at all. Expected is the eventualities that we are talking around it. The patient is still not dead, the victim is still alive, but probably is expected not to survive. And the black one is presumed for the dead one. So that is what IDME is all about it. The goal of disaster triage, maximum thing for the maximum people, maximum benefit for the maximum people. Simple thing, do the greatest good for the greatest number of potential survivors. The red ribbon is the highest priority of casualties to receive care, immediate life-threatening conditions, immediate management in order to survive, response to life-saving interventions. Any no, any answers, any resources, is it available, is it unavailable? D is for delayed. The yellow band would say requires medical intervention, but probably can be delayed by to a certain extent. Condition can tolerate to a certain delay, expected to survive despite that short delay. Response to life-saving intervention, ensure that the right medicines are made available, ensure that the right equipments are made available. Minimal is green, almost healthy, almost people with minor injuries and is managing themselves all by their own. So you are 80 to 90% healthy, probably not fit and running, but definitely can manage it. So expected to survive even if the medical treatment are not received. Responses to life-saving intervention, all your answers should be yes and does not need any additional things requirement. Expected casualty with absolutely slim chance of survival, not expected to survive given the situation, given the mental medical resources available. The responses to life-saving intervention? Absolutely no. There are no responses. In fact, any intervention done to the people, you are only wasting your resources, perhaps. Dead casualties with complete absence of life, not breathing for. So you need to, the cadaver need to be stacked in, tagged in, and found, respected families needs to be informed. Attempt basic life-sustaining effort only if the sufficient personnel are available. It is important not to move dead casualties unless the remains have been blocking in the life cartridges. So triage categories are what we are talking about. It is IDMED. So what is it? I for immediate, the red band requires immediate care. D is the yellow band, requires care that can be safely delayed without affecting the probability of survival. The green band consists of minimal, sick or injured but expected to survive with or without care. The gray band is the expected, alive, but with little or no chances of survival. Given the current scenario, and dead is a fatality with no sense and out of life being there. The trash tags, if you're going around it, communicate the finding. The moment you see the tag, the moment you see the band, the moment you find anything, you will have a better idea of what kind of victims you are dealing with. The trash tag will help you to understand the category, will help you to allocate resources accordingly. The category change, the patient tracking becomes much easier. Remember, the triage is both dynamic and continuous. Why? Because this is interchanging. If you are not, if immediate intervention, medical intervention is taking place, probably you are coming with a result which are where the victim is responding or not responding. In case it is not responding, you are putting it to the expectant level, right? Again, um, anybody from expected level, if you have sufficient resources, probably sufficient interventions are taking places, they might become a critical patient. And that is what is true with anybody who has been earmarked as a delayed with a yellow band. This material or this victim can actually deteriorate over a period of time and become an immediate criteria. So this is what I'm trying to instill onto the audiences, is everything is dynamic and everything is continuous, as the case might be. Minimal is again something which goes here, and from minimal it doesn't go to the immediate directions directly. But this is what happens. Why this minimal? People are physically healthy, probably it looks very healthy, but psychologically they are scared, they are scarred totally, and that what goes mm, weakens their immune system altogether. So mass casualty triage is continuous. On a primary triage is something which we have a different kind of brand. On its secondary triage, the colors of the brand completely change. On the tertiary size is what we are looking into it. It is becoming much more bleaker if you want to go around it. So yes, there are changes. There are fine prints, fine thing that goes around here. We have the primary triage, the secondary triage, the tertiary triage per se. Casualty transport and evacuation. The casualty must be prioritized every time for treatment as well as transportations to definite care. Avoid overwhelming in the closest hospital. Take to a far-flung areas, far-flung hospital. Probably it will take some time, but once you reach that hospital or the medical facility, proper care will be given. So transport priority patients to a local hospital, transport stable patient to a distant hospital, and treat minor injuries at the site itself. So that is what we need to go around with the casualty transport and evacuation plan. Immediate the red banded patients or victim to the nearby hospital. Patient who can be delayed can be further administered into to a distant hospital, and people who are with the green band can be directly given the medical interventions. Efforts to identify and track casualties should begin in the scene itself. From the very first moment, you should note on the record and the data, and probably this will help you to understand the footprints. Tracking officers must ensure everyone is accounted for. System can range from electronic system to triage stack to simply recording information on a piece of tape. Allow for more information to be added to a system as and when it becomes available as we go around it. Generally performed by specialized teams, demod, identify and examining the remains, moving deceased to the morgues, maintaining custody of the bodies until release, determining the reporting cause of death, returning personal items to family members, making final disposition decisions of bodies, and issuing of death certificates. That needs to be understood. This is what the mass fatality management would be all about. It. You need to identify the body, you need to attack the body, you need to inform the families, you need to determine the cause of the death, and probably hand over the body along with the death certificate, as the case might be. So yes, we need to adhere to the established health practices, clinical decision making, professionalism, challenging ethical dilemmas, and difficult decision making that goes around it. This is the professionalism that goes around it. So establish health practices where we categorize the victims on the basis of their severity of illness or injuries. Clinical decision makings as to what all resources have to be allocated to what all victims. Professionalism, being courteous to everyone, at the same time not delaying the interventions for critical patients. At the same time, ensuring that the people with less of an injuries or illnesses are also not being neglected. Being professional, challenging ethical dilemmas, at times the resources constraint makes a person put in a certain situation which it's of which we call as a catch 22 situation, and he or she must look into the ethical state of affairs, which all means of difficult decisions. If you are looking at allocating resources to a very critical patient, or diverting the allocated resources from a critical patient to another patient who might not be critical but a very important person, is it right or is it wrong? That is the question that you need to go around it. So yes, summary: mass casualty events occurs when a number of victims overwhelmingly overwhelms. Change perspective to the greatest good to the greatest number. Initial goals of mass casualty trials: to sort, assess casualties, to identify those with life-threatening injuries, and mass fatalities will often complicate mass casualty events. Require specialized training, specialized resources, specialized handling, as the case might be. So yes, mass casualty is a one-off event that might actually shake the very core of the conscious of the people handling with them. But we should keep in mind that we are looking to do the maximum benefit to the maximum number of people. We need to prioritize everything as far as victims are concerned, as far as resources are concerned, as far as doctors are concerned, as far as equipments are concerned. And once these are being done, if we can go by the copybook methodology, probably your conscience remains a little bit clear. With this, I come to an end of this presentation. Thank you for watching this video till the end.